leveling off a little bit here in the 80s. So, all right. So welcome everyone to the first virtual journal club sponsored by the SPD of 2022. I hope everybody's year is off to a fantastic start. We don't have a whole lot of announcements on our end, so I think we might as well just jump to it. So we'll have enough time for kind of discussion and the presentations as well. So I'm going to pass the mic, the virtual mic, to Lucy, who's going to do her first introduction of the night.
All right. It is my honor to introduce Phil Leboit. He is professor of dermatology and pathology and division chief of dermatopathology and oral pathology at UCSF. He is internationally renowned for his work on pigmented lesions and has published extensively on Spitz nevi and atypical Spitz neoplasms. And he is here today to share one of his most recent papers with us and talk about the utility of next generation sequencing for atypical Spitz neoplasms. Well, you want to take it away?
Yeah, well, thank you so much, Lucy. And it's an honor to speak to you all, and especially a pleasure to be invited by Dr. Cohn, who trained at UCSF, and hopefully I can. My goal is to end the evening with maybe a little bit less confusion than everybody has starting off, because even the people who are allegedly at the forefront of this area are confused, and I count myself amongst them. So let me just go to share screen here, and I'm not sure why.
Let's see.
So is the paper coming up on you guys' screen?
No, not yet.
Okay.
Oh, here we go.
There we go.
There we
go.
Thank you.
Yeah. So so this is a paper that was organized in large part by Padram Garami at Northwestern and by Artur Zembowitz. And it looked at how decision making was made by dermatopathologists based first on morphology, and then if given a chance to sort of peek behind the scenes at the genomics of spitzoid neoplasms. And there's a number of the leading dermatopathologists and spitzologists of the world in the battery of people that they were able to assemble. And a couple of things to just sort of begin with. What do you need to be able to do next generation sequencing on a melanocytic lesion? And you need a little bit less than with former molecular techniques. So with comparative genomic hybridization, which our lab was still occasionally does when we can't get insurance authorization for next generation sequencing, you needed 500 micrograms of DNA. And if you think about that, that's about a 0.4 millimeter thickness lesion that's about 5 millimeters across. Next generation sequencing needs less. It needs about 100 micrograms of DNA. And you can get that out of even a very substantial junctional lesion if it has really, really large nests. So that's a major advance. And then a second advance is that you get to see mutations and gene fusions. And the technology that was used for this paper was the Tempus platform, which not only does mutational analysis on DNA, but also looks at gene fusions with RNA. So it's given how many Spitz lesions are associated with gene fusions as opposed to mutations, that's a major advantage. What this platform doesn't give, though, is copy number changes. And those, if you want to investigate those, you still have to do it in another manner. At UCSF, the UCSF 500 next-gen panel that my colleague Boris Bastian set up is able to look at both mutations and fusions and chromosomal copy number changes at the same time. So this is great technology that was used in this paper, but it doesn't have that one other aspect. But for the purpose of this paper, what it was really doing was saying, okay, if we have morphology, how much are we adding to it by adding genomics? Does decision-making change? And so there were two iterations. In the first one, 60 cases that had been scanned and digitally imaged were sent to a bunch of dermatopathologists. And then it was redone, giving them also the mutational data. And that mutational data included what the initiating genomic event was, whether it was a mutation or a gene fusion, and then also whether there were progression events. So for those of you who are just sort of learning this language, the initiating mutations in conventional nevi are usually BRAF or NRAS. In the Spitz lesions, there are a couple that are initiated by mutations, usually HRAS and MAP3K8 and sometimes MAP2K1, but the majority are gene fusions, either receptor tyrosine kinase gene fusions or threonine serine gene fusions. So the ones that you're probably familiar with are the receptor tyrosine kinases ALK and NTRK1 and NTRK3, and the most common of the serine threonine kinases are MAP3K8 and BRAF. So in looking at these, there were a couple of things that that are notable. If you look at the majority of cases here, they were fusions. And then there were some other cases that were thrown in as kind of distractors, cases that had Spitz-like morphology. And the term we use for those now is Spitzoid. So they were Spitzoid lesions looking like a Spitz nevus microscopically that had been initiated by a BRAF mutation or an NRAS mutation or an NF1 mutation or a combination of those. But the great majority of these cases were the fusion cases. The really bad actors, the three that they highlighted where the patients died of distant metastatic disease, as in their case one, were cases that were in the conventional nevus to melanoma pathway, initiated by BRAF, and then had additional genomic events. So if you look at case one here with distant metastasis and death, it had an initiating mutation in BRAF and then a TERT mutation on top of that. So it turned out that after the pathologists involved were given the genomic intervention, the genomic information, they were much more readily able to identify the lesions that were had lethal metastatic potential. The three here with two of them with BRAF V600E and one of them with an NRAS Q61R mutation. And one thing I would note here that's really important is that even if you don't have access to next generation sequencing, you can screen for some of these. BRAF V600E is recognizable by the VE1 antibody, which is a new generation of mutation-specific antibodies. And it's reliable enough in terms of its ability to recognize the V600E mutant form of BRAF, that it's actually one of the antibodies that's on the market is FDA approved for treating BRAF mutant neoplasms. That gives you an idea of how robust it is. Case 2 is NRAS Q61R, and the Q61R mutation is recognized by an antibody called SP174. SP174 can recognize the HRAS Q61R mutation, NRAS Q61R, and KRAS Q61R. So it's very specific for Q61R, but it's agnostic in terms of whether that mutation is in NRAS, KRAS, or HRAS. So it's not quite as neat a tool in that you have to do a lot more correlation with morphology to figure out exactly what you're looking at. But that's important in that if you have a spitzoid lesion, one of the first steps in working it up is what pathway is it, and you can do that now to some extent with immunohistochemistry. You can stain for ALK, you can stain for NTRK1 pretty reliably. ROS1, the staining is not quite as good, and BRAF, the staining is pretty good. So in any event, with the ability to have the genomic data there, the recognition of these potentially fatal lesions went way up, and I think there were the cases that were fatal were then recognized by about 80% of the people who participated in this study. So in summary about the study, it really shows that having this data improves decision making, and I don't have the slightest doubt about that from our practice, where we have very granular data on a lot of Spitz lesions. This is not going to be by any means the very last word, because there's, in addition to genomics and transcriptomics, there's proteomics, and there's also the host factors. So in terms of being able to really analyze what people want to know, which is the Spitz or spitzoid neoplasm in my child one that's going to interfere with them growing into adulthood and having a healthy life? We don't have 100% prediction even with these techniques, but we have a lot better, we can sort of triage these into risk groups that are a lot more close to what parents are going to be wanting to know in terms of the risk that this poses to their kid, and also it's going to guide treatment in terms of follow-up intervals, etc. So I've gone close to 15 minutes, and I probably should allow some time for questions.
Thank you so much, Phil. That was it's a fascinating paper, and also I just appreciated your take on it as well. I think because of time limits, let's just focus on the big question that Elena Harlech asks in our Q&A. So you might know Elena. She's one of our pediatric melanoma researchers and experts, and so she kind of asked the question that you touched upon in your talk, which is that next generation sequencing is great, but immunohistochemistry can cover some of the things that NGS does. And how do you parse the cost benefit ratio of both techniques, and what would you advise maybe the practicing pediatric dermatologist to do?
Great question. So on a practical level, the very first thing is, if the size of the tumor is really small, please tell your pathologist, don't order levels on this. Because I've been in some very frustrating situations where there's an incredibly atypical tumor that's 3 millimeters in size in a child, and they've leveled through the whole thing. So you can't do anything. No immunohistochemistry, no NGS, et cetera. So preserving as much tissue as possible for the studies that are most important is sort of principle number one. Then principle number two would be to try to get as far as you can with immunohistochemistry, but not to the point of just throwing spaghetti against the wall to see what sticks, because that can use up tissue that you might need for next generation sequencing also. So the big question is it in one of the Spitz pathways, or is it in a conventional pathway? And in children, with the exception of large congenital nevi, NRAS is a fairly unusual mutation. So the big mutation that would push something outside the Spitz pathway is going to be BRAF V600E, and you can get that with a single stain. So if you have a lesion that's morphologically Spitzoid and it's BRAF V600E positive, then you're outside the Spitz pathway. You have to think, okay, could it be in the BAP1 inactivated melanocytoma group? And that's recognizable morphologically, and then you can get a BAP1 stain, and then you're pretty much done with that case. Or it might not be, in which case you could be dealing with a potentially lethal melanoma. If it doesn't stain for BRAF V600E and it's a Spitzoid lesion in a child, you're probably in one of the true Spitz lineages. And then if the morphology is good for a Spitz nevus, you're pretty much done there. If the morphology is worrisome, that's when you might want to look into other methods, and NGS is the best one to do. And without naming any labs in particular, I can tell you that a couple of the large genomics labs have a business strategy that's based on amassing data and on market share. And the good thing about that is that they have very liberal financial hardship policies. So one of them in particular has, in the San Francisco Bay Area, their definition of financial hardship is an family income of less than $160,000 a year. So if you can get the parents to go online and do the financial hardship thing, they can get their NGS done that way. And that's definitely going to sort of democratize the availability of this technology.
Great, thank you so much. There are a few questions that people have typed in the Q&A little box. If you have time to answer them, that would be great. But we will move on to our next journal now.
Great.
Thank you so much for that really helpful and informative presentation. The next person who's going to introduce our next set of speakers and presenters is Grant. So I'll pass the virtual mic to him.
All right, thank you, Joy. I'd like to welcome our next speaker this evening, who is Dr. Carrie Coughlin. She'll be presenting her recent publication entitled Care of Congenital Melanocytic Nevi in Newborns and Infants, Review and Management Recommendations. Dr. Coughlin is an assistant professor of dermatology at Washington University School of Medicine in St. Louis. She serves as the director of the section of pediatric dermatology, as well as the director of the Pediatric Dermatology Fellowship. Welcome, Dr. Coughlin, and thank you for participating in tonight's SPD Journal Club.
Thank you, Grant, and thank you to Joy and the rest of the committee for inviting me to speak, and I would say inviting us to speak. Also, Available for the Q&A portion of this are going to be Marla Jenke and Judy O'Haver, who are both co-authors on the paper. And I know we have several co-authors that are in the group today listening in and potentially asking other questions. We'll see. So thank you to you all for joining, and we're really glad to be here. So thanks for the invitation. Dr. Leboit, would you mind unsharing your screen?
Oh, I'm sorry.
Thank you.
Hold on a second. And okay, there we go.
Excellent. Okay, thanks very much. And thank you for your great talk. It's something that we all struggle with in terms of making diagnosis and thinking about other ways that we can get access to care for patients. And it's exciting to see new data and people's interpretations so that we can, at our own sites, decide how we're going to move forward with these diagnoses. So I'll be presenting our paper, as Grant mentioned, Care of the Congenital Melanocytic Nevi in Newborns and Infants, Review and Management Recommendations. This was published in Pediatrics. I have disclosures for me just because. So I have funding from the DF Foundation that is on a project related to congenital nevi, so somewhat related to this talk, and then a PEDRA grant that's not related. So our roadmap here, I thought for this presentation, it would be helpful to discuss how we came to writing the paper and what we focused on, what we included in the paper, and then at the end, some kind of lessons learned and tips from putting together this sort of paper in a collaborative way. So we're happy to have questions on both content and structure and function. So our journey here, it really starts in the clinic. So when we see patients with congenital melanocytic nevi, we have questions answered and many questions unanswered. And so thinking about these patients and my own clinic that focuses on nevi and melanoma, came together at a PEDRA meeting and talked with members of the Skin Tumors and Reactions to Cancer Therapy subgroup and the birthmark subgroup. And we kind of formed this working group of people interested in congenital melanocytic nevi and workshopped amongst ourselves what we wanted to focus on, really worked through putting the paper together. And then from that group, then figured out where we were going to publish and came up with this review that ended up in Pediatrics. And we really wanted to target a pediatric audience. So we're excited that that was our kind of home journal at the end of this. But it was a journey. It took many years to put this together, and that'll be something that we talk about in the lessons learned section. But I really do want to kind of drive home that anytime we're kind of talking about the paper or thinking about this population, it really is so that we can be better clinicians and provide better care to our patients. So we aim to write a paper that would be clinically relevant, assist providers, and that can be dermatologists, pediatric dermatologists, pediatricians, nurse practitioners, physician assistants, care teams, nurses, everyone on board, with triaging, counseling, and referral of these patients. And also to lay the groundwork for future work. We knew that the landscape of the literature might be sparse in terms of data and wanted to capture what was there and then potentially identify areas that could use some more work in the future. That would be something that potentially our working group or others within PEDRA and other groups would move forward with. So to get into the meat of the paper, you always think about, okay, what's your table one? Where our table one is basically a summary of the entire paper. So we break it down into sections on skincare and specialty management, surgery and procedures, and patient and family support. And within that table, there are kind of bullet point recommendations that providers can use to actually take a quick summary. Am I hitting the things that I need to be hitting when I'm seeing a patient? Am I thinking of the things I need to be thinking of when I see a patient? And it was a way to kind of summarize the paper so that a provider in a busy clinic wouldn't necessarily have to keep the whole paper in mind, but could have that as a quick reference to go back to. And I should say the way we did the literature review with this, so we did a kind of comprehensive literature review, and then a couple years into the process, did that supplemental review so that we could make sure to capture as many papers that were relevant as possible. We worked with librarians to be able to do that in a comprehensive way, and then really funneled down the data to include papers that were relevant within the body of the paper. So there's clearly many more papers that were pulled in the review than are cited in the paper, but we really cited the most relevant of the group. I'm going to talk a little bit about citation management in the kind of lessons learned section, because that was a big lesson learned for everyone in our group, how to manage that. But when we were thinking about skincare and specialty management, we found that there was not a lot of specific data to congenital melanocytic nevi, but there were general recommendations that made sense for kids that we could extrapolate would make sense for congenital melanocytic nevi. And we wanted to make sure to review some issues that people don't always necessarily think of when they think of nevi who are not pediatric dermatologists. So we talk about bathing and cleansing. Those recommendations are kind of gentle skin recommendations. We talk about wound healing and skin fragility, because that is something that we've noticed in clinical practice, and people did comment on in the literature that there was some differences in ability for wound healing and increased skin fragility in patients who have congenital melanocytic nevi. Talk about photoprotection, of course, but interestingly in the literature, there's not hardcore data on particular, say, risk changes for protecting skin or not protecting skin in congenital melanocytic nevi. And particularly when you think of the stat that potentially 2/3 of melanomas are CNS melanomas in this patient population, it does make you think a little bit about what that actual risk reduction might be. We talk about itch and pruritus and moisturizing, because that's something that had come up. And then also thinking about issues of sweating. So hypohidrosis or anhidrosis in the areas of congenital melanocytic nevi is something that people have seen in clinical practice, and also that we did find in our literature review, but the data is sparse. So particularly for wound healing and for the hypohidrosis or anhidrosis, there's not a lot of hard data. So that was something that we identified as an area for future study. We also talked a lot about management, and our discussions were kind of very in-depth on this topic because everybody's practice, it turned out, was similar but different, and there were nuances in the language. So we reviewed MRIs, so thinking about screening for congenital neuromelanosis, which would increase your risk of CNS melanoma. And it was interesting, amongst the literature, there's no consensus, and even amongst the group, people have different practices, as I mentioned, but thinking about the ages at which you would scan, the recommendations from the paper are typically earlier without contrast if you can, though that's not necessarily how everybody in the group practices. Then we had discussions about procedural interventions, either for cosmesis or for concern for melanoma. And then management in terms of how you observe. So clinical exams, lymph node palpation, how to use dermoscopy. And we don't have a primer on dermoscopy, but just the fact that repeated exams, repeated photos, and repeated dermoscopic images can help you follow lesions. And then it included discussions about even things like laser, where some people may use that in their practice and many others may not, but discussed some of the pros and cons, what you can get temporarily and what long-term results you will see. And again, the data is not super strong in the literature. There is a recommendation paper on surgical approaches and thinking about approaching surgery, but there are not kind of hard and firm consensus guidelines to imaging, to repeat imaging when you do that. The paper does, in my opinion, a nice job of kind of laying out the importance of what neural melanosis means, what risk that entails, and what specialty care a patient might need if they have that. So thinking about neurology, neurosurgery, also the secondary findings that may not be neuromelanosis, but that would be a finding that you could see on scans that you would need to address. We also have table 2, which is kind of the nitty-gritty numbers part of the paper, where we talk about incidence of nevi, which is, depending on the paper, quite low or quite high, up to 37 congenital nevi, up to 37% in one paper, but the numbers actually average lower. We talk about the subtypes of congenital melanocytic nevi, and then the categorization. So really the recommendations in terms of using the criteria for color satellites, if you will, and size, so that Kringle criteria, so that you can follow things over time. So a couple of things within this section, we really do use words specifically, and so tried to lay out in this a kind of a primer for what some of the words mean and to help people communicate more efficiently when talking about congenital nevi. And then when thinking about talking with patients, there's different approaches to talking about risk communication, but I wanted to put in this image of an icon array for anyone else who nerds out about health communications, that these are the sorts of images that you can think about using with patients to be able to to show visually what does it mean when we say that the incidence of melanoma in the population of people who have congenital melanocytic nevi might be 0.7 to 2.2%, or the risk might be 3 to 8% in the giant congenital melanocytic nevi subgroup. And then we move to table 3, which is a full page table again for patient and provider resources. Again, to make this kind of paper as approachable as possible and as user-friendly as possible, to also be able to target some patients in addition to the providers. So when thinking about a future review paper, a few things that we learned along the way. So the reference management was quite important. And we did this paper before I had taken a class on writing a systematic review. But as many of you may know, there are software programs that are super helpful in terms of screening, dual screening for different types of reviews. And Covenants is just one example, but it's a way to really track your screening process and your inclusion and exclusion criteria a lot more systematically and in one place. That's very useful. We were a big group from multiple institutions working over several years. Having an agenda and a point person and having that person really stick to the agenda and move the paper forward is definitely appropriate when you're trying to work with multiple people who all have their full-time jobs in addition to the paper that you're writing. So having a clear organizational plan from the beginning is actually really important for a paper like this. And then lastly, when we were thinking about publishing, we started with one journal and didn't quite fit there, and actually reached out to the editors at Pediatrics to talk about the paper, the content of the paper, and to see if it would be a fit with that journal. And then we ended up having a really good working relationship with the editors there. So one lesson I learned from this is when in doubt of where the fit would be, it is really good idea to reach out to a potential target journal, because they may be able to kind of guide you in a certain direction or help see the value in your work and try and convince others that it makes sense to publish in their journal, and can actually end up being an advocate for your paper. So I want to say thank you again to the committee for inviting me to present. We have clinical images within the paper about large and giant nevi, that's satellite nevi. We clarify in the paper that the term satellite, we're kind of veering more towards multiple instead of using that term satellite. So thank you. I've got the DF slide here. It's a great group. And then we're happy to answer any questions.
Thank you, Dr. Coughlin. That was a great presentation. One question I wanted to start off with was, there's a lot of, as you know, sort of differences in practices and when to MRI, when not to MRI to screen for neuromelanosis. And I liked how your paper laid out some author recommendations. The question is, what do we do with the abnormal MRI findings, particularly in children who the test is a screening exam and they're asymptomatic?
Sure. So amongst the group, we are definitely fans of involving neurosurgery if you're finding some of those things that are not neuromelanosis, right? So you can have cysts that are space occupying lesions. You could have other things that are concerning for tumors. So those things may be asymptomatic, but are things that need to be followed. So certainly partnering with neurosurgery, and then partnering with neurology for the patients who have congenital neuromelanosis, because they may not have symptoms. They could develop symptoms later. They are certainly at risk for seizures. You want to follow their development and also have neurology on board to screen for that. So while you may not do something, they may buy themselves another provider that's going to be helpful in their care team moving forward, and also potentially a better educator, like for a neurologist, educating more for the signs of seizures than you might be able to.
All right, and in terms of moving forward with next steps in research, this paper lays a great foundation. Where do you see the needs for future studies?
Sure. So a few things, definitely the wound healing and skin fragility, thinking about the hypohidrosis and anhidrosis, those were two areas. And then thinking about, this was, definitely not a consensus statement, right? So it's management recommendations. We went kind of into the weeds in that language because we had author consensus on many things, but didn't go through a formal, say, Delphi procedure. So it didn't really count as a consensus paper. But there's definitely could be a role for having consensus management paper, particularly when thinking about things like the screening and MRI and some of the procedural interventions, there's still a lot of discussions. We don't know what the appropriate interval is for re-imaging people who have neuromelanosis, if that exists at all. So those sorts of issues would be good to approach in the future.
Another question we have is, do you think ongoing genetic info on melanomas and congenital melanocytic nevi, which seem to show different pathways than ultraviolet related, may impact sunscreen recommendations for this population?
So that's a little bit what I was alluding to, in that we don't actually have kind of firm data on whether that photoprotection makes a big impact on the development of melanoma in this population. So yes, I like that idea, to think about, if we're not seeing those UV signatures, we might not have to be as aggressive in terms of recommending that.
And then we have another question, which I think will be our last one. Was a neurologist or neurosurgeon involved in creating the MRI recommendations? And if so, what was their input regarding screening utility in asymptomatic patients versus diagnostic testing in symptomatic patients? So
great, thank you for that question. We were a group purely from pediatric dermatology, so we did not have a neurologist or neurosurgeon involved. The idea in terms of imaging was that there were different types of imaging that were appropriate depending if you were doing a screening test or whether you were doing a symptom-directed test. For example, in the literature, if you were really going to do a symptom-directed study, you'd be getting contrast. You wouldn't most likely be doing an MRI without contrast. Whereas screening in a younger infant, where you would like to avoid anesthesia, there's data to support doing a non-contrast MRI to be able to do that screening. But so there'd be two different approaches.
Well, thank you again, Dr. Coughlin. We really enjoyed hearing about your publication, and I'll pass the mic to Jeff for our third paper.
Thanks.
Great. Thanks so much, everybody. It's going really well so far, and I'm really excited to present our last paper of the evening. And the presenters will be Dr. Afifi, who is a chief resident currently at UCLA Dermatology, and Dr. Marcia Hogeling, who is a pediatric dermatologist at UCLA as well. And they are going to be presenting their paper, Review of Traction Alopecia in the Pediatric Patient, Diagnosis, Prevention, and Management.
Okay. Just wanted to thank the committee for allowing us to review our review paper. Our review paper of traction alopecia in the pediatric patient was a narrative review that we looked at all the literature, as well as some of the other review papers and some of our own experience to kind of create recommendations and provide some clinical pearls, which I'll highlight in this presentation. So just in our introduction, we really want to kind of set the tone that like why in the pediatric population, and like what the importance of this. So the early stages of traction alopecia is reversible versus the later stages are irreversible. And then oftentimes hairstyles associated with traction alopecia are introduced in childhood. So in a study of African-American school children, about 17.1% of girls showed signs of TA. And then in a separate study of Chinese women aged 19 to 38 with TA, about 80% of them reported the hairstyle practice actually starting 10 years earlier, with the initial exposure starting at an average age of 10 years. So it's important to understand the significance of the hairstyle to the patient and parents to effectively counsel them. And really early intervention provides an opportunity to counsel before the development of scarring alopecia. A little bit about the pathophysiology. So TA develops from frequent tension on the hair root. And there are specific hair treatments that can alter the tensile strength of the hair shaft. And specifically, these hair treatments that we highlighted in the review are chemical relaxers, which are used to make curly hair straight or less curly. Perms can refer to chemically treated hair to make straight hair curly, but this terminology can actually be used interchangeably with chemical relaxers. So it's important to clarify with the patient and parents. And then hot comb pressed and thermally relaxed hair refers to the use of heat to straighten curly hair. Both chemically relaxed and thermally straightened hair has been shown to have a compounded risk for traction alopecia when it's paired with tight hairstyles. And this is possibly due to weakening of the hair shaft and ultimately reducing the threshold for mechanical damage. So we also went through several hairstyles in the paper, and understanding these hairstyles is really key to effective counseling. In the interest of time, I won't be able to discuss every hairstyle and every technique, but I just wanted to highlight some important concepts and to focus on some hairstyles that were highlighted in the pediatric literature. So extensions, braids, and cornrows in the context of TA risk are often characterized as tight hairstyles that are left in for about 2 to 3 weeks, or sometimes even 6 to 8 weeks with touch-ups. And this duration is often preferred due to convenience as well as the associated time to perform and cost of the hairstyle. And several studies have highlighted the importance of recognizing these associations because the typical duration of a tight hairstyle reflects the duration of exposure to tension on the hair follicle. Additionally, increased weight from extension can also increase tension on the hair follicle. And this is also something important to consider in patients with really long, thick, heavy hair. In regards to like buns and ponytails, the technique and duration can kind of be more intermittent and really dependent on the individual. And then hair practices involving turbans and their association with TA have been reported in the literature among Sikh boys and Turkish Islamic females. And turbans are usually left in throughout the day, or even they can be left in for 24 hours before they're removed and the process is repeated. Among Sikh boys who developed TA, there's an associated very tight bun that's under the turban, and among Turkish Islamic women developing TA, there's a tight first layer turban. This is not an inclusive list, and really when evaluating a hairstyle, it's important to ask about technique, symptoms, how long the hairstyle stays in for, and the importance of the hairstyle to the patient. So there have been several studies that have recognized certain hairstyles with a higher risk of TA. In a South African study that involved about 574 schoolgirls, the odds of developing TA was increased when braids, extensions, or weaves were applied to chemically relaxed hair versus when these hairstyles were used in non-chemically relaxed hair. So this highlighted the compounded risk of TA when chemically relaxed hair is paired with tight hairstyles. In that same study, among girls who chemically relaxed their hair, the odds of developing TA was higher in those applying braids, extensions, or weaves versus those who used ponytails. This suggests that the duration of hairstyle matters because braids, extensions, weaves are often tighter and left in longer, while ponytails are usually much more intermittent throughout the day. And several other studies have also noted that any tight hairstyle that results in symptoms of pain and pruritus or signs of inflammation is associated with a higher risk of TA. Some physical exam pearls. So oftentimes the pattern of alopecia mirrors the hairstyle. In the, this is an example, this is an adolescent Sikh boy who had some frontotemporal hair loss, and it was likely from tension from the turban and at the frontotemporal scalp was causing some tension, as well as that tight bun that goes under the turban too. The fringe sign is characteristic of TA, and it's a useful marker. It describes the presence of the retained hair at the temporal frontal rim, and then followed by the hair loss. And you can also see signs of inflammation on physical exam, which include some very perifollicular erythema and scale and pustules as well. On trichoscopic findings, some pearls, you can see some broken hairs, some miniaturization of the hair, and increased hair diameter diversity, but something that's more characteristic is the presence of white hair casts. And these are about 2 to 7 millimeter long gray white cylinders that are located at the proximal hair shaft at areas of tension, and it represents the inner and outer root sheath. And it's a good kind of marker for TA. there was a study that actually showed the disappearance of these hair casts after the patients had changed the hairstyle to a hairstyle that was involved less tension. So it can be like a marker of improvement as well. In terms of management, really what we wanted to highlight was prevention is instrumental at the reversible stage. So patient and family counseling is really key. And then studies regarding treatment in the pediatric patients are really limited. And a lot of the data really comes from the adult population. So some things that could be tried are topical minoxidil for regrowth, topical or oral antibiotics for inflammation, or topical or interlesional steroids for inflammation as well. But really what we wanted to provide is some prevention recommendations for this population. So within the review paper, we created a table that grouped certain hair practices into higher and lower risk of TA based on studies, other review paper, and expert opinions. But further studies are really needed to validate this table, but I just wanted to summarize it briefly. So a level 5 and 6 hairstyle is associated with the highest risk of TA, and they're hairstyles that apply longer duration of tension to chemically or thermally relaxed hair, or any hairstyle that results in pain or inflammation. A level 4 describes, in general, tight hairstyles or hairstyles with excessive weight on non-chemically or thermally relaxed hair. A level 3 we describe as more as non-relaxed hair with looser technique of tighter hairstyles or chemically relaxed hair with infrequent application of tight hairstyles. A level 2 describes more mildly chemically relaxed hair or thermally relaxed hair with infrequent application of tight hairstyles. And a level 1 describes non-relaxed hair with just loose, low-hanging ponytails and buns. So strategies to minimize tension that you can discuss with the patient and patient's family is avoid wearing hair tightly pulled back every day if possible. And really to go through with them the different hairstyles, higher and lower risk, and see which one of the lower risk hairstyles they prefer and see if they can plan out a rotation of hairstyles. And to consider chemically relaxed hair just be worn out completely if possible, or just do loose ponytails or braids. And if the patient or the patient's family really wants to do braids, cornrows, and extensions, then would recommend to defer chemically relaxing the child's hair. And then to loosen up the hairline when wearing hair pulled back or a turban. To remove or redo any hairstyle that is causing pain or irritation. And to teach children to communicate when something is too tight or painful. And to always have a professional chemically relaxed hair. So in summary, recognizing TA at its reversible stage is in the pediatric population really critical to prevent that permanent scarring later on. And then a thorough history of hair practices should be reviewed along with the physical exam to aid in diagnosis and management. And then pediatric dermatologists and really all providers should be familiar with hairstyles at higher risk of TA, as well as their significance to the patient and patient's family to really provide some practical solutions. I just wanted to thank the Society for Pediatric Dermatology, as well as my co-authors, wonderful medical student Nicole, and Dr. Hogeling, who is our pediatric derm faculty and our residency program director and my personal mentor. Thanks.
Great. Thank you so much, Dr. Afifi. That was great. And wonderful overview about TA, which I'm sure many of us on this in this journal club have a very hard time both counseling as well as managing. And there are some wonderful questions that have come in already. So I'm just going to go through them in the next few minutes. So one of the questions is, one of the challenges I have found with TA is acceptance of the diagnosis by the patient's parent. Does anyone have tips or tricks for helping parents accept the diagnosis so they can make appropriate changes?
Dr. I think maybe building rapport is really helpful in this situation, as well as if you can, provide further information about traction alopecia and maybe some more like resources for them to review, and maybe over time they could maybe come into terms with the diagnosis. That would be probably my initial thoughts.
Yeah, I totally agree. And I think that, part of it is the patient-physician relationship. And so if you know the patient well, it may be easier to bring it up, or they may trust you more as opposed to just bringing it up on the initial visit. I also think that this is, a reason why we need to have more diversity in our subspecialty, because sometimes patients, I think, will take the feedback better coming from someone from their own community, or who has a similar hair type. Or sometimes I find that, for example, with some of my Black patients, they kind of ask me like, well, what do you know about my hair? Because my hair is different from them. So I think that's one thing that can go a long way, but over time, once they get to know you, get to trust you, then I think they will be able to kind of work with you, and you can work with them on some of those suggestions.
Perfect. Thank you. Why does the frontotemporal hairline remain after traction, leading to the fringe sign?
I think the primary reason is that some of the hairs at the frontal hairline are often shorter and not involved in the actual hairstyle. And so that's why you can actually see the remains of the rim, and then the alopecias after that, because those are the hairs that are mostly involved and longer.
Great. Any recommendations for phrasing for approaching this topic and potentially at-risk patients coming to clinic for another concern?
So so how to bring it up if you're noticing it? Is that,
Yep.
Okay? Yep. I think if there's signs of maybe inflammation or any symptoms that they could potentially be kind of elicit some symptoms, maybe that can be the start of a conversation about it. And then I think also just having maybe just any informational handouts or kind of advocacy handouts in the clinic would also be helpful too, to help bring up the topic, or have at least the patient be can view those pamphlets if they wanted to.
Yeah, and I sometimes ask the parents if, I'll just say, like, when I was examining your child and I was examining the scalp, I noticed this. I was wondering if you've noticed this as well. Is this something that, a change in the hair that you've noticed, or something that you're concerned about, to kind of gauge their concern or whether or not they noticed it, and then sort of try and gently point it out to kind of bring up the conversation. And then you can kind of gauge how receptive they are about some of your other suggestions.
Wonderful. Dr. Rucker Wright wrote in the Q&A, thank you for reviewing this. Key is giving patients options and cultural sensitivity. I often discuss braid holidays and changing direction of polar tension. I think that's great advice. Any recommendations for community outreach to prevent this or warn children or families?
Yeah, I think that's definitely, we should consider that, and maybe our society education committee can come up with something that we could disseminate, or we could have information on our SPD website or patient handouts. I think that would be really helpful. We could think of other strategies to reach out to some of our local communities, maybe some of the hair salons that do some of these hairstyles.
Yeah, no, that would be a great idea. Dr. Silverman's asking, does the SPD have traction handout? I don't know the answer to that, but it's probably something that we can look at on the PSTERN website to see if they have one. If they don't have one, I think it'd be great to have a website to make a handout, especially based on this excellent review paper. Dr. Kenner Bell says yes. Maybe about having a handout or making a handout. I don't know, but we'll check. Recognizing, oh, they wrote one. Great. Awesome. That's amazing. Recognizing that it may depend on various risk factors, what is the general timeline for progression from a non-scarring to scarring alopecia with consistent use of a tight hairstyle?
I think based on the literature, it was pretty variable. Some people have a really rapid progression, while some people have a much longer progression. So it really was kind of patient dependent.
Yeah, it's very interesting. And I think your paper also showed that as they got older, there was a higher incidence. So we know that the more you do it, I guess. But the big question is, how long do you have to do it for? Great. Thank you guys so much for that wonderful presentation and the question and answers. And I'm going to pass it back to Dr. Wong.
Awesome. Thanks, Jeff. Thank you, guys, for that wonderful presentation. So that wraps up our first Virtual Journal Club of 2022. Thank you guys for all attending. For those of you still remaining on, we are going to try to send out a post-Journal Club survey, so look out for that in your emails, and we hope that you'll take the time to respond. Thank you guys so much, and we'll see you in a couple months' time. Bye-bye.